job as we're getting started today by introducing the individual who, to you, needs no introduction, Dr. J. Marion. But it's, for me, been a great pleasure to meet him and to know a little bit more about him. I think you're aware that he was a graduate of Vanderbilt University, where he pursued his doctorate of medicine, but also stayed on for his internal medicine residency and pursued fellowship subsequent to that at Barnes Hospital in St. Louis. His career has been active not only at Washington University, where he finished his fellowship, has been in private practice, but we were fortunate enough to have him join here back in 2004. Do I have that correct?
Yes.
And now has been a sustaining member of the program, rising from initially as associate professor to endowed professorship, impacting not only the Department of Medicine, but the School of Medicine in multiple areas, including having served as vice dean and others. I think it's been his abiding interest in care of the soul, not just the patient, thinking about how we approach that, and we're excited to have him talking to us again about the subjects of humanities in the care of the human. So Jay, welcome.
Dr. Bailey, thank you so very much. Yes, those of you who know me know, and I will introduce in my talk, that I'm very proud of the medical knowledge that I have, and I love applying it, but I'm also equally proud of the fact that I pay a lot of attention to the art of medicine. I've watched some master clinicians in my life and gone home and said, how can I be more like that person? So I was looking for a topic, and some recent articles I read, one by Arthur Kleinman and the other from Anatole Broyard, talked about the importance of being present with your patients and what does that really mean. And they all reflected the aspect of, to be humanistic, you have to be present. And so I thought, okay, well, I'll talk about humanism and presence. But then I started thinking to myself, how do you teach humanism? And that's when I got into starting thinking about, is there some structure in the humanities that will guide me? So let's start with Anatole Broyard, who's from New Orleans, who was from New Orleans. He was a literary critic for the New York Times. And he wrote about, we'll see in a little bit, his experience as a patient who ended up dying of prostate cancer. But you'll notice that I start my talk with a quote of his where he talks about lives having a beginning, a middle, and an appropriate end. And you'll see throughout my talk why that's important, because the structure of the humanities depends upon a beginning, a middle, and an end, and certain things happen in those things. But many of the medical students have heard me quote him before, because he was not very kind in his critique of us as physicians. And when a literary critic critiques our humanism, I think we're kind of forced to listen. And this guy, for his living, was a critic. And he said, to the typical physician, my illness is a routine incident in his rounds, while for me it is a crisis of my life. So now he understood that no doctor could sit with him 24 hours a day. He understood that the doctors had lots of other patients. But what he said that made this first part of his quote important, he says, I would feel better if I had a doctor who at least perceived this incongruity. If when the doctor walked in, even though I know the doctor had lots of other people to see, this is a crisis in my life. I've been waiting all day to find out what that bone scan showed. Do I have progressive disease? I would just like for the doctor to somehow acknowledge that for me this is a crisis. And he goes on later to talk about that way the doctor could do that would be through the doctor's presence. He said originally the patient was protected by the sterility of the hospital, and that was a good thing. He says sterility went too far. It sterilized the doctor's thinking. It sterilized the patient's entire experience in the hospital. It sterilized the very notion of illness and of ultimately dying of an illness. So how do we respond to such sharp criticism from someone who is skilled in the humanities? He was a literary critic. He knew the humanities. And so we have to remind ourselves that even though our technology and skills will not allow us to cure every one of our patients, although we would like to, it will be our presence that will always allow us to help create a space in which healing can occur. The other paper that came to my attention a couple years ago is Arthur Kleinman at Harvard, who was retiring after 50 years in clinical practice and reflected upon his whole journey as a physician. And I just love this line, we recognize presence by its absence. He says, I graduated 50 years ago from Stanford Medical School. Looking back on my experience as a clinician, teacher, mentor, researcher, and family caregiver, what stands out vividly are my memories of presence. And so I say goodbye to a half century of clinical work. Being a clinician taught me a great lesson in humanity. It has enriched and deepened my life experience. Not least, it made me more present to others and to myself. What stands out vividly are my memories of presence. By this, and he's now going to define what do we mean when we talk about presence, physicians being present for their patients. He says, by this I mean the intensity of interacting with another human being that animates being there for and with that person. Presence is a calling forward or a stepping toward the other. It's clearly active. You're not just in the room, it is active. It is looking into someone's eyes, placing your hand in solidarity on their arm, speaking to them directly and with authentic feeling. Presence is built out of listening intensely, indicating that the person and their story matters. He says a bureaucratic indifference on the phone of a barely listening health insurance representative or anyone who makes you feel that you and your questions don't matter, or simply going through the motions because that's all they need to do. And we've all been there. We've all been on the other end of a phone call or talking to somebody, a customer assistant person, who you can tell they don't want to be there. They're not making eye contact. They're looking somewhere else. They're not answering your question. They're answering their talking points. We recognize presence by its absence. He said, wasn't just talking about generic things. He comes back now to medicine. He says, I've had many experiences where I felt physicians and nurses were responding to their patients in this mechanical, dispiriting way, at times disrespectful, at other times as if uninterested and on autopilot, almost always while looking down and away as if there was no human being there. And now we have another obstacle, don't we? We have computers because we're oftentimes typing our note as we're talking to the patient. He says there's neither a good nor scientific reason for this sad state of affairs. It is a result of policy and programmatic bullying, bureaucratic hostility to what is most human in the art of medicine. And we've all experienced that as we've been told more about clinical productivity in RVUs, and yet the nurse tells you there's a patient who's not doing well and the family just arrived and they're very upset, they want to talk to somebody, but you're being told that you've got 5 people waiting in clinic and your productivity's down. So we kind of have this pulling from why we went into medicine, and that was to be present for our patients, versus a reality which is changing things. But he doesn't let us off the hook. Again, this is a man who's ready to retire. He says, physicians, let it happen. The enemy is us. We have failed to advocate for what we do best and what patients and families want. So yes, we do have these pressures of clinical RVUs, et cetera, but somehow some of us need to, at times, appropriately, not in a negative way, speak up and say, but there are times where I have to be present for my patient, and especially if it's an end-of-life discussion, it's going to take a little bit more than 2 minutes. And this is why I want to present this talk mostly to our younger doctors and medical students. He gave us a mandate. He said, young caring physicians need to be encouraged to cultivate their practice of presence, and health systems need to sustain that crucial practice. So that's one of the reasons I decided to give this talk, to encourage those of you who went into medicine for that warm and fuzzy feeling. You know, I want to help people that, you know, that Abraham Voorhees talked, you know, we talk about preclinical years and clinical years. Abraham Voorhees, who wrote Cutting for Stone, is at Stanford, he calls it the pre-cynical years and cynical years. He says you start off medical school and you're all warm and fuzzy, you go into medicine saying you want to help people. How many of you, when you applied to medical school and they asked you why do you want to be a doctor, said something on the order of I want to help people? Every one of us, right? Okay. And by the end of our third and fourth years, there are studies that show when they track vicarious empathy that it just goes down. By the end of the fourth year, the hidden curriculum has beat the warm and fuzziness out of us. And so at least what I'd like to do is keep reminding us that it's okay to be warm and fuzzy. So how can we fulfill Kleinman's need for young and caring physicians to nurture their practice of presence with each clinical encounter? What can the humanities teach us about the importance of presence? Presence during chaos. Why am I talking about chaos? When we meet our patients, there's been some disruption in their well-being. Nobody on Friday afternoon says, what do you want to do, honey? I don't know, I'm kind of bored. I know, you want to go see a doctor? Oh yeah, that sounds fun. Keep in mind, nobody does that. When they come to see you, there's something that they just noticed. There was their beginning, the world as it was, and now something new evolved, a new symptom. They feel up under their arm and there's a mass that didn't used to be there. There's blood in the stool. My right side of my face is drooping and I'm dysarthric. There's something that went on that shook their sense of well-being, and they are in their sense of chaos. Their focal point, by definition, is entangled with their sense of disruption. They were supposed to be going to watch their child in Little League practice today, but now they're in your office. There's been a disruption. There's been dissonance. Various people saying, oh, it'll be nothing. Somebody else saying, you better see a doctor right away. There's discord, suffering, and chaos. That is the perspective of the patient when they meet you for a new illness. Our focal point, however, is quite different. Our focal point is entangled with biotechnical issues. What's the diagnosis? What's this patient trying to tell me? What stage is this disorder in? What are the targets of my treatment? What would be the treatment? And how do I orchestrate all of this? Do I have them come get the CAT scan first, then the MRI, then the biopsy? How do I do all of that? Well, clearly, there's a disconnect between our patients' focal points and our focal points. And despite this, there's been very little formal training for how we respond to suffering. And most of our patients, when they see us, there is some component of suffering. How do we respond to suffering? Is it just giving pain medicine? As we know, the physical pain is the easiest pain to take care of. Spiritual, existential pains are much more difficult. I've got a medical student here with me who is in Ronnie B. George. She's going to talk about an experience that she had where she witnessed suffering, and it wasn't even the patient suffering. And she'll tell you about that. So instead, we tend to default to our comfort zone. We do what we do best. It's Maslow's hammer. And remember Maslow's hammer? If you're a hammer, every problem is a nail. As a physician, everything has a what, when, why, how, and where are we going to do it? So to talk about the art and science of medicine, I'm going to read you 2 letters. And these are patients that I took care of at Barnes Hospital, Washington University, 30 plus years ago. The first is from a woman I met 35 years ago, and every year I get a letter from either her or her family. It's one of those that's got a bunch of pictures, and they tell me what everybody's doing. She had completed successfully therapy for Hodgkin's disease 35 years ago. And her last letter said, Dr. Marion, I want to thank you for helping me so many years ago. I'm enclosing a recent picture of me, my husband, my son, and our dog. I can't speak for the dog, but my son, husband, and I are very appreciative of what you did to cure my Hodgkin's disease. She then went on to describe several events in her life that she wanted to share with me. Now, does that make me feel good? Sure it does. It's a woman who's cured. But does it make me feel that good? Am I really excited about that? I'm going to tell you no. And the reason I'm going to say no is because I am very aware that I just applied some skill sets that I had learned during my oncology fellowship that allowed me to make the correct diagnosis and prescribe the right therapy. And this is why I don't feel special that I was involved in her cure. This woman, if she had seen any oncologist, they would have come up with the same diagnosis. The pathologist would have said it's nodular sclerosing Hodgkin's disease. The radiologist would have said it's stage 3. And I would have said at that time she needs MOP chemotherapy. And so would have anybody in this room. So I know that she was cured because she had a curable Hodgkin's disease. There were other people I took care of that got the same therapy that weren't cured. So yes, I feel good about this, but she's introduces me when I meet her family time and time again. She says, this is my hero, this is my savior. No, I'm not. I'm really not. I just applied the science of medicine that I'd learned. I'm proud of that. I don't want to take that away from anybody. But that's not what makes me feel really proud about being a physician. The second letter is from a woman I met 34 years ago when she was a young pre-teenager. Even though this was the first time that she had made contact with me in 30 years, I remembered her very clearly. The second I saw her name, I knew her story. I started to even tear up, and you'll see why later. And her letter read, you probably don't remember me since you take care of so many patients. You were taking care of my mother when she died 30 years ago today. She then went on to remind me of her mother's name and illness, although, like I said, she really didn't have to. I already knew who she was. She thanked me for the care I had provided to her mother and to her family. She said, you promised that you would keep Mom comfortable in the end, and you kept your promise. And then the zinger. Of equal importance, you helped me with the most difficult task in my life. You helped me to say goodbye to my mother. That is what I remember the most about you. My father and I are doing fine, and we speak of you often. So both of these letters remind me of the great privilege I enjoy being a physician. The first acknowledged the fine-tuned scientific skills that allowed me to diagnose and successfully treat Hodgkin's disease. The second letter acknowledged aspects of care that are harder to define, and that's humanism and the art of medicine. As a matter of fact, the second letter I got was from a patient who died, or from the daughter of a patient who died. And you can see why that letter may be more important to me, because I didn't cure her disease. She died, but I got a letter from her family. So what is humanism, and from which medical text can we learn it? As I was preparing for today's talk, I realized that humanism is something that I'm still learning. I watch my patients and their families struggle through episodes of illness and suffering. I'm not learning it from a textbook, but I'm learning it from the bedside. Yet today I ask myself to talk about humanism in medical care, but how do I teach something that I can't define? Where do I start? And that's when I thought about the humanities and said, well, the humanities is the study of humanism, so maybe I should look at the humanities and see what they can teach me. And so that's what I did. So what can the humanities teach us about humanism? More specifically, what can tragedy, comedy, and music teach us about humanism? And the punchline that I realize is they share a common thread. Every aspect of the humanities has a common thread. There's the beginning. Remember, Anatole Broyard talked about the beginning, the middle, and the end, and he said we spend most of our lives in the middle. The world as it is. Then in the middle, there's some event that introduces disruption, chaos, discordance, dissonance, turns the world upside down. And then there's a conclusion where there's some catharsis which allows the chaos to create a space where healing or a new beginning can return us to a new harmony. Now that sounds interesting. Is it true? So there's this cycle of harmony, and if you think about your life, from day one of your memory, there was some harmony, something disrupted. You weren't picked for in second grade, you weren't picked for the softball team. You have discordance and chaos, you have a catharsis, you start feeling better, life gets back to a new harmony, and then you're not asked to the prom or something like that, and it just keeps going. So some medical students wrote in academic medicine their experience with patients and their crisis that they saw in their patients. And they said the chaos settles, life returns to, I don't know why it did this, normal. That's supposed to be one word. Yet we are left to pick up the pieces in the silence after the storm. So let's look at classical music. And as you listen, I'm going to play 3 little pieces from Adagio by Samuel Barber. If some of you saw the movie Platoon, will recognize this. There's a beginning, and I'm going to ask you to listen. Do you hear the harmony? In the middle, is there dissonance, discord, and a catharsis? It's almost like there's going to be fingernails on a chalkboard where you just want to get out of this room. It's going to be painful to listen to. But if you listen through it and make it through it, you'll hear the conclusion where I'm going to suggest to you that the catharsis allows for a new harmony. So let's see if we hear that. So let's start with the beginning and listen for the harmony. Maybe a little sad, but certainly harmonious, not hard on the ears. Now let's listen to the middle. Listen for discord, dissonance, chaos, even a catharsis at the end where it just finally you say enough. Let's listen to the end and see if there's a return to harmony. So I think in this piece of music, the structure that I defined, the beginning, middle, and an end, hold true. And you can think of other classical pieces, Scheherazade, where very beautiful violins, and then it becomes very discordant, disruptive, and goes back to harmony. And actually, Scheherazade cycles several times through that. But some of you don't listen to classical music. What about classical rock? Think of Bohemian Rhapsody, how it starts off with Freddie Mercury, very harmonious, and then it becomes very discordant, goes back to harmony. I didn't choose that because of all the publicity it recently had with the movie, So I chose another piece of classic rock, and that's Stairway to Heaven. And let's see if we can see harmony that leads to disruption, discordant, catharsis, which takes you back to a new harmony. Let's see if even classic rock fulfills the structure that I'm defining for the humanities.
There's a lady who's sure all that glitters is gold, and she's buying the stairway to heaven.
Okay, now let's listen and see if we hear disruption, discordance, and ultimately a catharsis. Now, does this catharsis take us back to harmony at the end?
And she's buying a stairway.
I think it does. Now, a similar structure can be found in humor. But first, I want to ask you all a philosophical question before we talk about humor. If I'm standing alone in a forest when I say something, and my wife Carol isn't there to hear me, am I still wrong? Now, some of you laughed. How does that structure fit into the humanities? Well, there was a setup. The comedians call it a setup, but it's the beginning. It's the world as it was, normal, harmonious. So when I started my setup by saying, if I'm standing alone in the forest when I speak, what were you thinking of? What sounds philosophically similar to that? If a tree falls in a forest and no one's there to hear it, does it still make a sound? So the setup was you were thinking there was going to be maybe perhaps a normal, rational question. But then there was a punchline, which would be the disruption. Because your brain was thinking I'm going to be talking about trees falling in the woods and nobody there to hear it, but I threw in the punchline saying, am I still wrong? And that was this unexpected deviation, the disruption or discordance. And then there's the laugh, which I would define as a catharsis, and that's the sound your brain makes when you're pleasantly surprised. And that sets the stage back for the next joke. So if you've ever watched a comedian, what happens if a joke fails? And there's no laugh. It is very hard for that comedian to get back on track because they're expecting to go from chaos, the laugh, back to a new setup. And if the joke fails, we've all seen comedians where they just look terrible. What happens if our brains are not allowed the catharsis of laughter? And again, I'm going to be emphasizing why we have to stay present. What happens if we are not allowed the catharsis? And in what situations can the catharsis of comedy be suppressed? Well, if a joke is based on a recent tragedy or is politically incorrect, we're not allowed the catharsis of laugh and we're left uncomfortable. We've all witnessed the unfortunate person who unintentionally embarrasses himself. We've been on an elevator, just you and one other person, and the other person passes wind. Well, if there's only two people in the elevator, everybody knows who did it. Our instinct to laugh is usually suppressed by our maturity and empathy. And you can't wait for that elevator door to open because you are left really uncomfortable. What do you say to the person who just embarrassed themselves? Okay? You're not allowed the catharsis of the laughter. And so it's awkward and you want to get out of there. So instead we fall into awkward silence since we weren't allowed the catharsis that would be needed for us to have a reset. So we've talked about music, we've talked about humor, and we've said you have to remain present during the discordance before you can return to the harmony. So healing requires your presence and cannot occur if you leave before the catharsis, and this is going to tie into us as doctors. There will be times where a patient is having a meltdown or the family's having a meltdown, and you could say, well, I'm sorry, I got to get back to clinic, I'll come back later, or I'll send in my medical student, but you have to stay present. So back to our question, what lessons can we learn from the humanities that will allow us to create a space for healing? Again, the same pattern that I've defined for you in music and in comedy occurs in our patients' stories. They have health. That's their beginning. And as Anatole Broyard says, then there's this long middle where some illness introduces disruption, and there is some conclusion. Either the patient's cured or the patient dies or something bad happens, and there's an opportunity for healing. So let's look at the structure of storytelling and see. I think I've maybe convinced you that in music and in comedy, this is true. What about storytelling and tragedy? So I want to share a personal story with you that I think will help us decide if I'm right. Years ago, I was taking care of a middle-aged woman with a husband and a 12-year-old daughter. Early in the course of her illness, my patient was being treated for an aggressive but potentially curable cancer. She had a breast cancer. Premenopausal is very aggressive. We now know it would probably be defined as triple negative. We didn't know that many years ago. Her daughter would show up with her during most of her appointments and treatments. Back then, we didn't have all the best antiemetics that we have now. And treatment was really hard for people, and they needed cheerleaders. And clearly, she was her mom's cheerleader. She was always there. But my patient's remission only lasted a year before she relapsed with widespread disease. And over the next year or so, we tried several salvage chemotherapy regimens. But her disease was always one step ahead of us. We'd get a stabilization of disease for 6 months, and it would start up again. And when she had exhausted all reasonable therapies, we began to discuss her goals for end-of-life care. Her daughter, who was now 14, became angry at everyone, including her mother. She was angry that the treatment didn't work, so she was angry at me. She was angry at her mother because she viewed it that mom isn't fighting hard enough. She became distant. She stopped showing up to her mother's appointments. Without her daughter present, just her and her husband had multiple discussions with me, and finally she chose end-of-life care with hospice so she could be home with her family, her dog, and the people and things that she loved. Now, this was maybe 1987. Barnes Hospital in WashU, we set up our first hospice program in 1984. I was junior faculty. I had finished my fellowship in '82, so I was volunteered to be the hospice medical director, and it ended up becoming, I think, my identity. I actually enjoyed that more, so I sometimes jokingly refer to myself as a recovering oncologist. So I was now still involved in this person's care as a hospice director. I'd make home calls on her. And her daughter was always in another room, never present. The patient wanted to be at home in home hospice so she could be with her family, but she was never there. During my last visit, the nurses had called me saying, I think she's going to go today. She's got agonal respirations, her pulse is thready, I don't think this can go much longer. Can you come talk to the family? So I finished rounds and went out there. And the daughter was so angry, she confronted me on the front porch. Mom isn't even trying. She won't eat and she sleeps all the time. How much longer can this go on? What is she waiting for? If she wants to die, why doesn't she just do it already? I think we can call that a catharsis, maybe. Even though her mom appeared to be in a coma, I made some suggestions to the daughter. I talked to her about nobody wants to have their last act on earth be a failure. You've asked what's mom waiting for? Maybe mom doesn't want to leave as a failure. You need to talk to your mom. So I suggested that you tell your mom, even though we don't know if she's going to hear you, she might be able to hear you, she might just be too weak to speak. You need to tell her how much you love her and how proud you are to be her daughter. I said you need to tell her that Dad and you will be okay if she leaves. I said to her, you need to give your mom permission to go. Please let her go as someone who doesn't feel that she's failing. Give her permission. It was a long conversation, but the daughter finally understood. There was a lot of tears. And so I told her I'd stay with her. She went up, she laid her head on her mom's chest and spoke those words. And the room was just a tsunami of tears. There were nurses there, volunteers, other family members. Everybody was crying, and I was too. And I wanted to be someplace else. I didn't want to be in this room. This was too painful. That evening, my patient died. Hope you would agree this is a story that's hard to listen to. But like all meaningful stories, there was a beginning, the world as it was. There was a disruption and chaos when the mother relapsed and chose not to take further therapy. And there was a catharsis, the daughter's meltdown. But I've already hopefully convinced you that the structure of the humanities suggests that the catharsis is supposed to create the space for healing to occur. Where's the healing in our story of a teenage girl having to say goodbye to her mother? Did I get this wrong? Have I finally blown it? My little model for the humanities doesn't work here. Where's the return to harmony? And those of you who are paying attention to the early part of my talk know where this is going. Remember I referenced 2 letters? Remember the second letter? Now within the context of this story that you just heard, might this be our return to harmony? The second letter, I'm going to read it again, was from a woman I had met 34 years ago, and she's a pre-teenager. Let's again look at her letter. You probably don't remember me since you take care of so many patients. You were taking care of my mother when she died 30 years ago. And please excuse me, I still get emotional with this. You helped me with the most difficult task in my life. You helped me to say goodbye to my mother. That is what I remember the most about you. My father and I are doing fine, and we speak of you often. Now, would you agree that our story fits the structure suggested by the study of the humanities? There was indeed a return to a new normal, a new harmony. Now, if I didn't engage the daughter, just said, oh, she's just being a difficult 14-year-old, I may have never given her that permission to say goodbye to her mother that she needed. because 34 years later she says, thank you for doing that. You let me say goodbye to my mother. She might have been feeling terrible forever about the fact that her mom died and she never said goodbye. So I think it argues for us to remain physically and emotionally present during the disruption and discordance caused by illness. So what is the need for presence? As Anatole Boyer talked about in his personal experience, for us as doctors, yes, it's just another patient on our rounds. But as Anatole Boyer said, for me, it's the crisis of my lifetime. Now, feeling sadness is not good enough. We talk, the medical students all get a bunch of lectures on empathic communication skills. Being empathic is not enough. To move from empathy to action, because ultimately you want to do something active, we must show that we're connected to their struggle. And we show that through our presence. So let's go back to Kleinman and see what he described as presence. He said the intensity of interacting with another human being that animates being there for and with that person. Presence is a calling forward or a stepping toward the other. It is active. It is looking into someone's eyes, placing your hand in solidarity on their arm, speaking to them directly and with authentic feeling. Presence is built upon listening intensely, indicating that the person and their story matter. That's what presence means. It's active. It's not just being there. Now, I like this line, knowledge without wisdom is dangerous. That's why guidelines alone can't tell you how to be a good doctor, because that just gives you some data. You have to decide when it's wise to use various things. But wisdom without action is useless. What doesn't matter if you're wise, but you don't act on it. So during mindful practice, and we're going to talk about what does it mean to be mindful, we combine our medical knowledge with the wisdom of the patient's story to create empathic action that connects us through reflective presence. And we're going to talk a lot about reflection. Before we go any further, I'm going to give you some commands, and I want you to respond as fast as possible. Okay, as fast as possible. Spell joke, everyone. Spell poke. What do we call the white of an egg? Some of you say yolk. Okay, now what does that mean? You fell into the trap of not being mindful. You kind of heard poke, joke, and you heard something about an egg, and so the obvious thing I was looking for was yolk. And we've all been there where we're having a disagreement with somebody, and as they're presenting their case, we're busy in our head thinking of what we're going to say next, and communication fails. So to be mindfulness, you have to be mindful of the patient or self in the moment. So you have to have a pause, and then you bring in your presence. And presence can be reflexive or reflective. So those of you who said yolk were reflexive. It was a reflex, joke, poke, yolk. Those of you who thought about it and said albumin or the white of an egg were reflective. Now, some of you will know that this is a picture of a ring. It's a three-dimensional ring. It's got the Phantom of the Opera, the face. You can feel its nose and everything. And I wear this all the time. And the fellows who work in oncology and people who worked with me know why I wear this. It was in 1988, I guess, 87, 88, when Phantom of the Opera the musical was playing in New York, and you might know that, some of you might not know, Sarah Brightman and Michael Crawford were only allowed to perform in the United States for 6 months because of the American Actors Guild Union. So they had 6 months here. Nobody could get tickets. I was able to get tickets, not through anything I did. I was in St. Louis, and TWA had their program for training flight attendants. And one of the leaders of that program was a guy named David. David was a gay man, and he was dying of AIDS. And his friends, many who were gay, knew people in New York in the gay community, and they were able to get tickets. And they asked, would you take that? David wants to see Phantom before he dies. Would you you willing to take him up there? And I said, sure, I will. And on the way to the airport, from the airport to the hotel, I heard something that was really important to me. Because I was wondering, I'd already been in practice for like 6 years, and I was wondering, how many more times can I tell somebody they're going to die and be authentic? I was worried about that. You know, am I going to become reflexive? Is this going to be a reflex? I heard on the radio, they were interviewing Michael Crawford on public radio, and they asked him, how much longer can you do this role of Phantom? You've already done it for a year in London, you're doing it 6 months here, then you're going to Toronto. How much longer can you do it? And you know what he said? He solved my problem without even knowing what my problem was. He said, have any of you seen the play or the musical? The very last line, the Phantom gives the engagement ring back to Christina. And then his last line of singing is, go now, turns away, go now, and he sings, it's over, the music of the night. And as he's singing that, he says, I have a tear going down my cheek. The first time I sing that line, and it doesn't evoke a tear, it's time for me to move on. Because it might be the 10,000th time that I've sang that line, but for you in the audience, it's your first time hearing it. If I'm not authentic, it's time for me to go. They gave us these rings. David and I both got a ring. And I've kept it on, even though Phantom of the Opera is something 20 plus years ago. Whenever I have an end-of-life discussion, the residents and fellows see me, that I look down at my ring, I touch it, and I create that space again to be mindful. I remind myself, okay, I've done this maybe 5 times this week, but for this person, it's going to be the very first time they've heard that they're going to die. So we recognize the absence of presence when behavior becomes reflexive. I think that's what Michael Crawford was saying, not reflective. So how are we doing at LSU with Arthur Kleinman's mandate? I'm here to tell you I think we're doing tremendous. Nicole, do you want to come up? Nicole was one of our Ronnie B. George scholars this year, and this year I decided to have them do something different. I wanted them to do some, Dr. Bailey's suggestion, some reflective writing of what they experienced. Not about, oh, I liked Ronnie B. George, but something that they took home. And I suggested the 55-word story, not 54, not 56. It has to be exactly 55-word narratives. And you might have heard Pascal may have been the first person to say I would have written a shorter letter, but I didn't have the time. We know Mark Twain said I would have written a shorter letter if I had more time. And talk less, say more. And there's a whole medical literature on this. If you look up 55-word summaries, you'll see even last month, JAMA does a lot of it. Military medicine does a bunch of it. And I like where they say writers and readers of 55-word stories gain insight into key moments of the healing arts. The brevity of the pieces adds to both the writing and reading impact. So they say that we should use it to help train young physicians. And so I asked the students to notice something and reflect on it. So and Nicole did something that was phenomenal. So if you want to introduce your story.
Okay, so I'm Nicole Sanders. I'm a second year, and I had the pleasure of getting to participate in RBG. And so this is a paper I wrote about my 55-word story. And so just as kind of, I guess, a preface, I was rotating with Dr. Kavanaugh in the cancer clinic, and she had to meet with a man whose cancer had come back, and basically they had gone through aggressive chemo, and she thought it was best that they didn't take the most aggressive step. And the patient was okay with that, but the daughter there was not, and you could tell she was crying, she was upset that she really wanted the more aggressive approach. And Dr. Kavanaugh recognized that and kind of shifted the focus away from the patient, which is, for me as a second year, I was like, oh my gosh, like, you're supposed to be looking at the patient, but she focused it on the person who was actually hurting at the time. And I think that's something that is reflective of her encounter and her as a doctor. So I said, on June 19th, 2019, in the Digestive Cancer Clinic, I heard the words, "The cancer has come back again." Yet this time, I was on the other side of the news. It was the first time I heard those words since my brother's relapse in 2005. I did not watch the patient's face during the visit. Instead, I watched the daughter's face because I remembered how that news affected my family 14 years ago. I could tell she was taking everything in and weighed the options that the doctor was giving. But when the doctor was finished, I could see the tears slowly filling her eyes. As the doctor confronted her, her tears began to dry and a smile slowly emerged. In 2019, I learned that cancer treatment involves more than just the patient. So this was just, I guess, an attestment to the presence and how it affects more than just the patient. Like I said, my brother was diagnosed with cancer in the summer of 2005, and he was actually diagnosed, so it was an osteoblastoma that got reclassified as an osteosarcoma in the spine. So we actually got the cancer diagnosis twice, and I was only 9 years old at the time, but I remember going up there and my mom, speaking of presence, she could have left me behind, but she said, I made the conscious decision that I wanted my entire family there because cancer treatment is going to affect the whole family, whether you believe it or not, and I can attest that's true. So I know that for us, when we got to St. Jude, we were met with presence as soon as before we even walked through the door. The nurses were there, the team was there with a wheelchair for my brother, and wheeled us back, and the doctor, was talking to my parents, but then he turned to me and he was like, "Do you have any questions?" And I was a 9-year-old girl. I was like, "No," like, "You're here to treat him." But looking back on that now, that was crazy that the doctor saw me important enough to address me in this situation that was life-threatening for my brother. And when I go back, I ask my parents, what questions, how did that go? Like, how was that going with the doctor when they had to tell you? And they said, they were very direct in telling us that it was cancer, and they were very confident in their approach, and we just kind of put blind faith in them. And whenever I asked Evan, did you have any concerns? He was like, I was 12 and I turned myself off. So I had all blind faith in my parents. So kind of looking back at that, my brother's putting blind faith in the parents. My parents are putting blind faith in the doctor. And now I'm coming into the role as a doctor and I'm like, wow, that's a lot. So I think that attests to the fact that if they're going to put all the blind faith in us, we owe it to the patient to give them a little bit of presence during the time that's kind of shattering their lives. And we, as a doctor, experience that chaos that you were talking about, the middle part, for as long as that interaction is with your patient, whether it be 5 minutes, 10 minutes, 20 minutes. But the patient's going to experience that for as long as they are living with that disease. So anywhere from, 6 months, a year. For us, it was 2 years. And I still will get a little upset about it, but and that's why this moment was so strong and powerful to me, because I remember feeling the way the daughter felt, because I felt scared, and I was like, why am I scared? I'm not going through this. That's my brother. My brother's going through this. My parents are having to make the decisions, but really, it still affects my life in a way. And as a doctor, I think that's really important to realize that it's going to affect not just the patient. We're going to have words that's going to affect, it's going to be a ripple effect, and it's going to affect their family members and their friends. And so Dr. Kavanaugh, when she went and put her hand on the daughter, kind of justified that daughter's feelings of being okay and being scared, being okay to cry, which I think is kind of hard whenever we're in the busy lifestyles. But whenever she was allowing her to cry and do that, she was allowing her to feel the catharsis that you were talking about. So she was able to feel, able to be okay with the treatment options. And in turn, the patient, her father, was okay with it as well.
Yes, Dr. Kavanaugh mentioned that it was very clear that Dr. Kavanaugh mentioned that it was very clear that the father was okay. He was okay with his mortality. He kept looking at his daughter, and Dr. Kavanaugh, who was obviously in the moment, she was mindful, recognized the patient is not my target here. It's his daughter, and he wants me to address her, and she did. So now again, that last slide was not 55 words. I want you to see what a master did with taking that story, and if you count, it's not 54 words, it's not 56. We spent time working on these with summaries, but you want to read yours?
Sure. Okay, so this was my 55-yard story based off of all that. It said, lips quivering, tears lingering on the bottom eyelid, head falling. Her dad's cancer is back. He doesn't want chemo. The doctor offers a less aggressive approach, and he agrees. But what about the daughter? What is the treatment for her grief? What are the multiple choice answers for that question? It's simple. Words of comfort.
Thank you, Nicole. Thank you so much. So you can see that I think this whole concept is alive and well at our school. I think Kleiman would be very pleased with what we're doing with our young medical students and young doctors. So in conclusion, to respond to the critiques of Arthur Kleinman and Anatole Broyard and many others who've addressed this, we must remind ourselves that despite our great advances in technology and skills, and I started my first letter with somebody I had cured with Hodgkin's disease, despite all of that, we're not going to be able to cure every one of our patients, but our presence will always allow us to help create a space where healing can occur. And hopefully by now you recognize the difference between healing and curing. So your white coat may allow you to cure, but it'll be your presence and the person behind the white coat that will allow you to heal. So go forward, be advocates for what we do best, and be present for your patients and their families. Thank you. Any thoughts, questions, similar stories to Nicole's?
So Nicole and Jay, I just want to thank you for telling us and reminding us that we don't treat patients, we care for patients, and framing that so well for us today. Are there observations others have?
Would another word for presence be compassion?
Yes.
You know, that movement from empathy to action.
It's true, but compassion I can feel internally. Presence is, as Kleiman described, as taking that empathy or compassion and acting on it. So it's bad enough I walk out of the room and say, oh, that was terrible, that was hard, let's go see the next patient. The patient needs to know that you felt that compassion. And that means like what Dr. Mindy Kavanaugh did. Mindy was one of the first medical students I taught when I got here. She was in my Module 1 small group 15 years ago. Mindy's turned into a great doctor, those of you who know her. And she was able to see quickly, this guy's not upset, it's his daughter, I need to address the daughter. And as Nicole told us, she did that seamlessly, right? Anything else? Well, thank you so much. I appreciate you letting me share this with you.